ICD-10 coding and medical documentation changes for family and internal medicine. One, it's a little late, 6:30 on the East Coast, 3:30 on the West, but we decided that I would give everybody, later in the day, possibly hours could be towards the end or even done on the East Coast, so we wanted to experiment with doing the webinar at this time. So I want to thank everybody for attending. So today will be about how ICD-10 implementation will impact medical documentation and coding for family medicine and internal medicine practices. All attendees are now joined in listen-only mode. And to ask any question or make a comment during the webinar, on the bottom right of your screen, there will be a questions area section. I will get to them at the end of the call. If for some reason we're not able to answer your questions, we can email you the answer at a later date, shortly after this call. But I should be able to answer any ICD-10 specific questions. Keep in mind, the focus of this call is more training on the, and not on where I within MTBC. I will get to that at a high level at some point in this presentation, but the majority of this presentation is about changes from 9 to 10. So today we're going to cover the following topics. We're going to talk about a strategy to map your 9 codes to your 10 codes, and we're going to focus specifically on family and internal medicine. We will have, I should say, on other specialties, dermatology, podiatry, and pediatrics, to name a few. We've got laterality and specificity. Try saying that 100 times, but we're going to be saying it a lot now with ICD-10, since we do need to get more specific with our coding. Examples of ICD-10 changes regarding laterality, we'll go over that. We'll go over some new combination codes in 10, which is actually a good thing because it's one code instead of many codes that we had in 9. We're going to go over some new screening status and follow-up codes in ICD-10. We'll go over some personal families and family and internal med for ICD-10, and some new non-compliance codes in ICD-10. And like I said, if you enter all your questions in the chat window at the end of the presentation, we will go over those questions. Okay, so the mapping strategy. Clients, MTBC run a report to identify your 50 most frequently used ICD-9 codes within claims in the last 6 months. This tends to be at least 80 to 90% of your usage within internal family medicine, your hypertension, your diabetes, cholesterol, high cholesterol, and so forth. All others, what I recommend is whatever system you do have currently, go into your practice management system, run a report, and identify the top 50 most frequently used ICD-9 codes. So that's your starting point. If you want to go up to 100, that's up to you. But 50 usually covers the majority of your usage percentage-wise. And then you would use a tool to map these 59 ICD-9 codes to ICD-10 codes. Again, I should state that for existing clients, we will provide that service, the mapping of your top 50 ICD-9 codes to ICD-10 codes. Of course, it'll be a lot more 10s than 9s. The average ratio is about 3 to 1 across all codes. Certain specialties, it's a lot higher. So some recommended tools are aapc.com/ICD-10/codes. If I go to that tool, waiting for it to come up, you'll see that that's a translator that allows you to put in an ICD-9, such as 401.1, and it will translate it to ICD-10. Okay, the same thing with 10 to 9. If I put in I-10, which happens to be the code for hypertension, it'll tell me all the 9s that map to it. In this case, there's 3 9s to that 1 10. That's not typical. typical. It's the reverse, where there's multiple 9s to 10. But that's service. Okay. Another great tool is ICD-10data.com. It's a great tool because it allows you to search both 9 or 10. So again, you could do 401.1, hit search, central hypertension comes up, it allows you to central hypertension. If we take something a little more complicated, 250.61, which is diabetes with neurological manifestations type 1, not stated as uncontrolled, and that is the ICD-10 code E10.40. Okay. So these are both great tools, and it even has the index built in, both the tabular A through Z, and external cause index, table of neoplasms, and table of drugs. So it's pretty neat. Okay. This is another thing where you can type a couple of digits to find 939 or ICD-10 code to convert. So you could type 401, and it tells you it. If you want to see all the codes under diabetes, this is going to be a lot bigger, and it starts to show you. Okay, that was a non-specific code, so it tells you have to do child. Okay, so those are some great tools, and that's what we recommend for 9 to 10 mapping. Okay, if you're still using a paper Superbill, you need to determine how many pages the new 10 Superbill will be. Obviously, it may be more than one page. So if you have your mapped ICD-10 codes, and let's say that translates into, let's say, 225 ICD-10 codes, I don't think you're going to fit that on one single-sided sheet. You may fit it on 2 single-sided pages, but how easy is that for a physician or a coder or what have you to easily find the code? So AAPC happens to estimate that for most specialties, the ICD-10 use regular will triple that of 9 code usage. So, and that's being conservative. That would be 50 to 150. I think it's more like 50 to 200 or 50 to 225 is the average. And I've done some analysis to show that. So it's much more difficult for physicians and staff to use a Superbill now that there's going to be this many more codes. So the best option is MTBC will offer an electronic Superbill, which many of our clients are using, that can accommodate as many 10 codes as the practice would like to include for charge capture. So that's really the recommended strategy. Let's talk about laterality. The 10 codes are 3 to 7 characters in length and total over 68,000. While 9 codes, you know, are 3 to 5 digits in length and number over 14,000. One other point is the 10 codes actually are alphanumeric, and they start with a letter, whereas the 9 codes, of course, are all numeric. And the chapters are all start with specific letters. So all OB codes begin with an O. Cardiac codes begin with an I, like hypertension, CAD, what have you. Okay? So laterality and specificity account for the majority of the new codes. Okay? So some examples of laterality would be hip pain, breast cancer, humerus fracture. You're now going to need to specify right, left, or bilateral. Please note, in bilateral, sometimes there is actually one ICD-10 code. Other times you actually need to code left and right. So let's talk about specificity. Okay, so we have fractures. Fractures are much more complex. You need to get to the specific site, such as the surgical neck of the humerus, the laterality, whether it's right, left, displaced or non-displaced, whether it's the initial visit, subsequent visit, or a sequel, meaning a late effect would be the sequel, or an open or closed fracture. So you can imagine how many more fracture codes there are. It's a lot more. It's like a 10-to-1 ratio for each code, at least. So an example would be this code, S42.225A, is a two-part non-displaced fracture of the surgical neck of left humerus, initial encounter for closed fracture. So again, as far as internal medicine and family medicine, you're not going to be needing to code these a lot, but you can imagine when an orthopedist is going to be going through a lot of change. And MTBC will help with an EHR be able to capture these charges in a more logical way, such as choices for displaced or non-displaced, open and closed, initial, subsequent, sequel, and so forth. Crohn's disease is changing, and that will affect both internal and family med. Before it was very nonspecific. Now it's small versus large intestine or both, with or without complications. And the complications that you can choose from a coding standpoint will be rectal bleeding, fistula, intestinal obstruction, abscess, or other complications. So an example of a code, this would be K5811, is Crohn's disease of both the small and large intestine. Okay. So you could see they've really expanded that. Some more laterality examples would be limb pain. In limb pain, we only have one code in 729.5 for ICD-9. Okay? There's arms, legs, left, right, what have you. And ICD-10 is more in laterality, upper or lower. Not upper arm, pain in right thigh. This is one area right away. I'm sure in your documentation you state pain in right leg. There is a code for pain in right leg, not just pain in right thigh. But obviously the more specific, the better. It doesn't mean you're going to get denied, but I wouldn't use limb pain unspecified anymore. I would at minimum say right leg, right arm, left arm, right arm, in both the documentation and of course the code. Need to code two codes for bilateral limb pain. So somebody comes in and says both my right and left forearm are bothering me. Well, there's no code for bilateral. You'll have to code M79.631 and M79.632. Breast cancer, there is a code for right and left within each different site of the breasts. The malignant neoplasm of the lower, female breast, left female breast, and unspecified. Okay? And again, pretty much in the documentation it should say right or left. So needing to code unspecified should only be used as a last resort. Now let's talk combination codes. Diabetes, it's going to be, in my opinion, easier to code because before you would have to code 2 or 3 codes for diabetes with manifestations. And ICD-10 is just one combination code. So two very nice examples are type 2 diabetes with neuropathy. In the 9, you'd have to do 250.60, which is telling you have type 2 diabetes with some neurological manifestations, and 357.2, which is polyneuropathy and diabetes. You have to code them both. Or in 10, there's just one code, the 11.40, type 2 diabetes with diabetic neuropathy unspecified. Okay, so the specific neurological manifestation is within the code itself. Same thing here with type 1 diabetes with retinopathy with macular edema, except this requires 3 9 codes. 250.51 for saying it has ophthalmic manifestation, 201 for the retinopathy, and 36207 for the macular edema. Well, there's one code, E10.311, that covers type 1 DM with the retinopathy and the edema. So that makes things, in my opinion, a lot easier. Now, also, pressure ulcers, which is, of course, very common in the hospital and nursing home setting. So I'm sure many of the practices on the call use these codes. We'd have to code 2 codes now, one for where the location and one for the stage. And ICD-10 is one combination code. So an example would be stage 2 pressure ulcer of the elbow, where in 9 it's 70701 for the elbow and 70722 for stage 2. Well, in 10, it's 2 possibilities because it depends if it's the right or the left elbow. 9 didn't specify laterality. It's just one code, though, saying also right elbow stage 2 ends in a 2. If this was stage 1, this would end in a 1, L89011 instead of L89012. Same thing with any body part. So pressure ulcer of hip, there's 2 codes, in 9 and only one code in 10. So, and there's other combination codes, but those are the two of the biggest one changes for your specialties. As far as changes to screening and status codes, this is going to be a bit of a change because obviously well-adult exams are constant within your world, and you just do V70.0 now. Well, there's two codes now in 10. There's a without abnormal findings and a with abnormal findings. And the codes with abnormal findings, you need to use an additional code for abnormal findings. And again, that's for anybody who's 18 or older at the date of service. So if somebody comes in and it's physical and they also have shortness of breath and what have you, and you're even diagnosed them with asthma, you could code the Z00.01 with an asthma as an abnormal finding or shortness of breath. Okay. It's yet to be determined yet if you're going to still split that up as far as E&M is concerned, but please check back with us when we find it out. But the payers have not said that yet. As far as annual well child exam, it's the same thing, except this would be anybody under 18 instead of V22. It's going to be Z00121 with abnormal findings, Z00129 without. Okay. So that's a change. Same thing with annual well woman exams, with or without. So on a routine GYN exam, now as V7231, there's two choices in 10. So if somebody comes in and they have dysmenorrhea as well, you would code the abnormal and then code dysmenorrhea as secondary. Okay. Other new codes that I find interesting that you probably want to take advantage of. One would be an encounter for a follow-up exam after complete treatment for malignant neoplasm. That's an important change, Z08, so if somebody's coming back, not just oncologists, but even in the internal side, first time coming back after chemo, that's a good code to use. And that would be a primary code because it's an encounter code. Same thing for screen for diabetes, for blood work, Z13.1. And then new, of course, is the acquired absence of amputees. It was very, very generic in the ICD-10 world. But now you got to get very specific. You don't have to, but you can, and it obviously is more clear. So you could specifically say the right or left upper limb below elbow. There'd be specific codes for that. History and family history codes, not much change. I mean, interestingly enough, there's no laterality needed when it comes to personal history of malignant neoplasm of breast or lung and bronchus, even though there are 2 breasts and 2 lungs. Because of personal history side, they specify in 10. So you got to look for those consistencies or inconsistencies within 10, and the more you use it, the more you get to know. This is what I do all day long, so obviously it just becomes old hat after a while, just like 9 is. Personal history of diabetic foot ulcer is a new code, so I want to point that out. There are some new history codes. And there's now personal history of in situ neoplasm codes, so that's one of the breast. That's a new code. Non-compliance codes are much more specific. I think in 9 we really only had the one, non-compliance with medical treatment. I think it's D15.81. Don't quote me on that, but I believe that's it. Well, anyway, we get more specific now. Z91.11 is non-compliance with dietary regimen. 120, 128 are intentional, either due to financial hardship or other reasons, like I don't want to take it, so I took less. And then there's also a code for due to age-related debility, underdosing. Okay, that's 130. Let's actually repeat that slide. So now I want to talk a little bit about MTBC status and where they're at. Well, their web EHR and eClaim module will be live by May 2014. Okay, at that point, that just means that at that point you will definitely be able to use the system as if it's your coding and charging out in 10 world. Of course, you won't actually be submitting 10 claims until 10.114. Okay, and MTBC will be communicating with their clients the various testing stages in the upcoming months. They were beginning late December, early January of 2014. As far as testing with ICD-10 for payers, Medicare right now isn't offering any kind of ICD-10 testing. AMA is not happy with this. Either is MGMA and many other associations, and they're trying to get this reversed. And they happen to be the biggest payer that had testing. As of now, they don't. But I think that's going to change. So only time will tell. Medicaid and commercial payers for over second quarter. Okay, I happen to know that it's going to be, I think, around March. They'll be ready to test. MDN, we have successfully tested the 837 claims file. So we've done dummy testing just with the new ICD-10 format, and it has passed. So that is good news. And we'll begin testing your specific claims to MDN sometime in the second quarter of 2014. So look for communications either via regular mail or email or the Secure Support Center. It's yet to be determined if we may use all methods because we need to make sure you follow up with us on all those testings. There will be a dedicated follow-up team also to help practices when any ICD-10 coding-related clearinghouse rejections or pay denials. And that's post-10-1. So in other words, you know, we do expect, the whole country expects that there will be issues post-ICD-10 with certain payers. And we need to, of course, support you on that, and we will. Okay, so we will have a dedicated follow-up team. So that's it. I mean, I just want to, before I get to questions, and this was a lot quicker than I thought it would go. When I practiced it, it didn't take, it took longer. So these are the main contacts, ICD-10@mtbc.com for any questions related either on this presentation or testing or basically anything related to 10. Or you could dial our main number, 732-873-5133, extension 308. So now I'd like to take questions. So let's see. I'm going to pull up the questions. The only question I have is a comment that the sound was muffled and speaker may be too close to microphone. Certainly, anybody else, if you have any questions, I'd like you to type it in now. I'm surprised that no one has any questions. I'll give a minute here. Did anybody else, if everybody could just type yes or no, anybody else have trouble hearing me during this presentation? Please say yes or no. Yes meaning you had trouble, no meaning you heard me fine. I have one response saying no, so it depends on, I guess, your speaker system. So again, there's no questions. I'm very surprised. Oh, okay. Do you think, I did say this, do you think errors in proper coding will be the basis of denied claims? Yes and no. I mean, Medicare stated that you can use unspecified for a year. I think at that point, after a year, Medicare will get more specific and start making you stay left, right, and things more specific, especially left and right, definitely. So I would get into the habit of doing left, right all the time because it's on the documentation anyway. If not, it should be. I mean, if you're operating on somebody's knee and it doesn't say which knee you're operating on, or if you're doing a follow-up and doesn't say where the knee pain is, whether documentation specific, and the commercials, I think they'll be more aggressive. But I also think they'll give at least 6 months before they begin to not deny for these new, more specific codes. Somebody asked the question, if a patient goes to an ortho doctor with a broken lower thumb and you submit the code for broken lower thumb, will this be denied by insurance? Will this be denied by insurance? I mean, again, the initial visits most likely is done in an emergency room, right? So you'd have to use the subsequent code. Remember, there's 3 levels: initial, subsequent, and sequela. So any time within the course of treatment, other than the initial visit, you'll use subsequent. There'll be a 7th character. I believe it's a D. I don't have those memorized. A is the initial. I think D is subsequent, and S is for sequela. Sequel will be a late effect, but a year later there's pain in the arm, or and then where that fracture was, and you can code that sequel code. So it would be denied if somebody already submitted an initial code, right? And then another doctor tried to submit an initial code again for the same arm within a certain amount of days. It would be considered a denial, considered a repeat, basically. When can MTBC let us try out the 10 codes? That's going to be sometime within first quarter. I would say earliest February, latest end of March. You'll be hearing from MTBC directly. To see if rejected, you'll be able to see if claims are rejected basically at the same time. You'll be we'll be testing with the with MDon sometime in second quarter. So you'll be testing, and you should be able to quote unquote play around in the system using ICD-10 first quarter, February through early April, and then mid-April to mid-May you'll be able to test directly with payers. Assuming the payer is ready, with MDon, I should say. Is there any point in getting 2014 ICD-9 code books if we're just going to have to buy ICD-10 ones? There is no point in getting ICD-9 codes for 2014. They're not making any changes, so if you do need to resubmit claims, which you most likely will, the 13 would suffice. Trying to get to the next question. If rejected, how long till we keep trying to get it correct? Don't really understand that question. Basically, they would give a denial reason, like there will be specific ICD-10 code denial reasons that are new that we're going to all need to be getting familiar with. CMS has not released those at this time. They will, and the commercial payers will follow. When can we officially start using all ICD-10 codes? October 1st, 2014. As far as, again, testing with an MTBC, first quarter 2014. But they don't go live. And, of course, you'll be able to submit 9 claims within MTBC's product as well, because obviously you'll need to resubmit claims that may not have paid yet from prior to 10-1. Can we get a short format of internal medicine office visit? That sounds like a specific question related to the EHR that I cannot answer, but if you just email info@mtbc.com or call in a customer service, you'll be able to get that answer. So, again, we're going to be doing more of these on specific. I know there's some podiatrists on this call and some dermatologists on this call, or at least they signed up for the webinar. There will be specific ICD-10 coding and medical documentation changes on those specific areas, such as bunions and foot pain and areas that doctors deal with hammer toe. Obviously, there may be more specific, whether it's right or left, what have you. Same thing with dermatology. We'll definitely do one on pediatrics. So please email the ICD-10 at mtbc.com if there's any specific coding you'd like me to cover in future presentations. I don't think there's any other questions, so I want to thank everybody for attending. We got through this pretty quick. And I hope to either see you hear you in a future webinar or over email. So please stay tuned for further communications related to MTBC's rollout. And if you're not an MTBC client, you should go with us because we're going to be one of the few vendors left, at least at this price point, that's ICD-10 compliant. Thank you and have a good day.